Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is Clostridium Difficile. C. difficile varies by region and population and is often higher in developed countries. Nosocomial infection, especially in the vulnerable and elderly, is the usual source of this infection. Risk factors include long-term hospital stays, long-term antibiotic use, older age, and comorbidities. C. difficile is a gram-positive anaerobic rod-shaped bacterium and is transmitted via the fecal-oral route. The spores which it produces are resilient and can survive in the environment for long periods of time. C. difficile produces two toxins, which are enterotoxin and cytotoxin. Clinical manifestations depend on the severity of the disease. So in a mild to moderate disease, the patient experiences diarrhea, abdominal pain, fever, and nausea. In more severe cases, they may experience severe abdominal pain, bloating, ileus, and even toxic megacolon. The manifestation is known as pseudomembranous colitis, which comprises white plaques on the colon lining, leading to inflammation and damage. Complications can also arise, including sepsis due to bacterial translocation and systemic infection, perforation of the colon due to the risk of intestinal rupture in severe cases, and mortality due to complications, particularly in the vulnerable populations. Diagnosis of C. difficile is based on stool samples, specifically to detect toxins A and B genes. The management is firstly to stop the causative antibiotic and then start the patient on either oral metronidazole or, in more severe cases, vancomycin or fidaxomicin. Of course, this will vary by region and local hospital guidelines. Okay, now let's try a question. So which of the following statements is true? A. C. difficile is diagnosed through a blood test detecting C. difficile specific antibodies. B. Fecal microbiota transplant, or FMT, is not recommended for patients with recurrent C. difficile. C. C. difficile infection is not associated with antibiotic use. D. Vancomycin and fidaxomicin are preferred antibiotics for treating moderate to severe C. difficile. Or E. Hand sanitizers containing alcohol are effective against C. difficile spores. So the correct answer in this case is D, that vancomycin and fidaxomicin are preferred antibiotics for treating moderate to severe C. difficile, and you may remember this from our earlier discussion of management. If we just run through the other answers though, so A is incorrect in this case because C. difficile is diagnosed through stool sampling, not blood sampling, and we don't look for antibodies, we look for the toxin genes. Fecal microbiota transplant is recommended for people with recurrent C. difficile. C. difficile infection is associated with antibiotics, making C incorrect. And E, the spores are in fact resistant to many hand sanitizers. And so E is incorrect. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.